Now, let's talk about the last part of this big topic called diabetes mellitus, and these are the diabetic complication. We divide this diabetic complication into two parts, the acute and the chronic. Acute diabetic complications are also known as diabetic emergency. Okay, acute diabetic complication are known as diabetic emergency, whereas chronic diabetic complications are further divided into macrovascular and microvascular complication. Macrovascular means atherosclerosis, whereas microvascular complication can be nephropathy, retinopathy, and neuropathy. So this is another big topic. So let's start with diabetic emergency or acute complication of diabetes. Now see this. These are diabetic ketoacidosis, hyperosmolar hyperglycemic state, lactic acidosis, and hypoglycemia. Diabetic ketoacidosis, hyperosmolar hyperglycemic state, lactic acidosis, and hypoglycemia. So let's talk one after other. Let's start with diabetic ketoacidosis. Diabetic ketoacidosis, or DKA, is the hallmark of type 1 diabetes. There's no doubt about it. In terminal cases of type 2 diabetes may be seen, but for for your level, for the undergraduate level, you just simply answer it is a feature of type 1 diabetes. This is a metabolic emergency in which hyperglycemia is associated with metabolic acidosis due to greatly rise ketone bodies, and the level, if we measure, is usually more than 5 millimole per liter. So there's a combination of things going on here. One, hyperglycemia. Second, ketone bodies production, which leads to metabolic acidosis. It is usually seen in the following circumstances, like previously undiagnosed diabetes. They may manifest for the first time with DKA in type 1 diabetes. Second, interruption of insulin therapy may lead to DKA, because without insulin, there is a high chance of ketone body formation, and the stress of intercurrent illness. Intercurrent illness are a stressful situation to our body. They can lead to release of counter-regulatory hormone, which simply elevate the blood sugar level. So they can just precipitate diabetic ketoacidosis in type 1 diabetes. Okay, let's move further. What is the pathogenesis? How this complication occurs? Ketoacidosis is a state of uncontrolled catabolism associated with insulin deficiency. So this is a catabolic state. Remember, insulin is anabolic hormone. In this case, there is no insulin. So it is insulin deficient condition. So the reverse will occur. That is catabolism. Insulin deficiency is a necessary precondition, since only a modest elevation in insulin level is sufficient to inhibit the hepatic ketogenesis. Every student knows this point already. That's why in type 2 diabetes, there is no diabetic ketoacidosis development, because a bit of insulin is already present there, and insulin will inhibit the ketogenesis. Other factors include counter-regulatory hormone excess and the fluid depletion. Now see that. So what are the counter-regulatory hormone? Can you take the name once again? What are those?
Glucagon.
Good.
Glucocorticoids or growth hormone.
Glucagon. Growth hormone, thyroid hormone.
Thyroid hormone.
Catecholamines.
Very good. Very good. So I already got all the names there. First is glucagon, second glucocorticoid, third catecholamine, fourth growth hormone, and even thyroid hormone you can list there. Okay, thyroid hormone is less important than the others. So glucagon, okay, first on the list. Glucocorticoid or cortisol, catecholamine, growth hormone, and thyroid hormone. These are the counter-regulatory hormones. So they are excessive in case of diabetic ketoacidosis. And there is fluid depletion as well. Let's move on. Now see there. So all of you, please focus on this slide. This is the mechanism of ketogenesis in diabetic ketoacidosis. So triglyceride, okay, from the adipose tissue will be broken into free fatty acid, isn't it? Because insulin is a lipogenetic hormone, and this is a case of insulin deficiency. So there is lipolysis occurs. When fats are broken down, free fatty acids are released. These free fatty acids will be taken up by the hepatocyte or the liver cell, okay? And see this is the mechanism that occurs in the mitochondria of hepatocyte. So fatty acyl carnitine, okay, will be formed, then will convert into acetyl coenzyme A, then acetoacetate, acetone, and beta hydroxybutyrate are other types of ketone body, and they will come out and they are raised in the blood. So these are the three important types of ketone body: acetoacetate, acetone, and beta hydroxybutyrate. Now see that. So those are the mechanism occurs inside the hepatocyte. But what about the other overall general mechanism? There is excessive glucose in the diabetes. This excessive glucose leads to hyperglycemia and glycosuria. No need to explain. This is very easy to understand. This glycosuria will lead to osmotic diuresis. Osmotic diuresis. What does that mean? It will carry water along with electrolyte, okay, and then they're excreted in the urine. So it will lead to fluid and electrolyte depletion, which results in renal hyperperfusion, and there is impaired excretion of ketone and hydrogen ion, which leads to metabolic acidosis in the patient. On the other hand, there is excessive synthesis of ketone body, which leads to ketoacidosis. Ketoacidosis can result in vomiting and the release of the ketones in the breath, including the acetone, also known as Kussmaul breathing, which further aggravate fluid and electrolyte depletion in the patient, and the final things occur. This is the slide which we already discussed in our previous class, but this is such important in the context of this topic. So I am repeating it once again here. All of you, please pay attention. There's a lack of insulin first. This lack of insulin will lead to increased secretion of counter-regulatory hormone. Look at the name here: glucagon, cortisol, growth hormone, catecholamine. So there is decreased anabolism and increased catabolism when there is lack of insulin. Decreased anabolism leads to hyperglycemia, glycosuria, osmotic diuresis, and salt and water depletion, resulting in hypovolemic shock, which can lead to death of the patient. And these are some other related problems. Increased catabolism leads to glycogenolysis, gluconeogenesis, and lipolysis. The important one are glycogenolysis and lipolysis here. Okay, that can result in formation of the ketone body, circulation of ketone in the blood, which is known as hyperketonemia, leads to acidosis because they are the acidic substance, and this condition is known as diabetic ketoacidosis. So to summarize, in case of diabetic ketoacidosis, we have to prove certain things. One is this is the patient of diabetes or type 1 diabetes, number one. And this patient should have high level of blood sugar. Second, this patient should have formation of ketone body or presence of ketone body in the blood or in the urine or in the breath. So ketone body should be there. Okay. And third point, this has to be a case of metabolic acidosis. You have to confirm or prove that with arterial blood gas analysis. Now let's a bit of elaborate this mechanism once again, though I'm sure you have already understood. In the absence of insulin, rapid lipolysis occur, leading to elevated circulating free fatty acid. These free fatty acids are converted to ketone body within the mitochondria of liver cell. You know that already. Accumulation of ketone body produces a metabolic acidosis, but this is not the only mechanism for metabolic acidosis. Remember, Severe dehydration or hypovolemia also results in metabolic acidosis because of shock, because of decreased tissue perfusion in the periphery. There is synthesis of lactic acid there, and that can further contribute in the formation of metabolic acidosis. Vomiting leads to further loss of fluid and electrolyte, which is a common feature of ketoacidosis. The excess ketone are excreted in the urine, but also appear in the breath, producing a distinctive smell, and this is known as acetone breath. Okay, acetone breath. This is very easy to diagnose. Respiratory compensation for the acidosis leads to hyperventilation, and this is known as Kussmaul breathing or ear hunger. This is deep and sighing type of breathing. Okay. This patient looks like he's really breathless, but if you measure the pulse, if you measure the oxygen saturation by pulse oximetry, it is near to 95 or near to 97 or 98%. That means there is no problem inside the lung. Okay, this is known as air hunger or Kussmaul breathing. Now, what are the clinical features of diabetic ketoacidosis? What are the symptoms and signs? So let's quickly, we'll go through them. These are the common symptoms: polyuria and thirst. These are the common symptoms of diabetes. Weight loss, definitely. Weakness and nausea and vomiting. Cramping of the leg, blurring of the vision, and abdominal pain. All of these are either the features of hypovolemia or dyselectrolytemia. Hypovolemia or dyselectrolytemia. Both of these are occurring in diabetic ketoacidosis because of osmotic diuresis. Regarding the sign, dehydration is very common. It can even lead to hypovolemic shock. Now see this, hypotension is a part of hypovolemic shock. In the beginning, it just may be postural or supine. Later on, okay, there is a clear-cut hypotension. There are cold extremities and peripheral cyanosis because of decreased blood volume. Tachycardia is an important feature. Air hunger, which is known as Kussmaul breathing, deep and sighing type of respiration, smell of acetone, hypothermia, and confusion, drowsiness, or even coma occurs in 10% of the cases. And sometimes a patient of diabetes, when comes with coma in the hospital, it is very difficult for us to identify without investigation, I'm saying, whether this is a case of insulin overdose or case of diabetic ketoacidosis. But we already talked about that, how to differentiate. Let's move on. Now, how to manage? How to manage the case of diabetic ketoacidosis? Now, one of the important point I like to highlight in the beginning, diabetic ketoacidosis management is considered, okay, as one of the big step towards becoming a good doctor. So please listen carefully. If my senior has given this responsibility to me, this is a patient of diabetic ketoacidosis, and it's your job to manage this nicely. Now, this is a big job in my hand. Why I'm saying like this? Because time and again, I need to take the blood sample from the patient. Okay, somebody should help in this regard, and means nurses there. Okay, this patient should be admitted in the ICU. ICU care has to be provided. Okay, the adjustment in insulin dose has to be done. Frequent IV fluid has to be given. Potassium has to be given. So this is a very important type of management. See this? How to diagnose it first? Okay, you already know. One is confirm this is a case of hyperglycemia by measuring blood glucose, and usually the blood glucose is in the range of 250 to 300 or even higher than that. Second, prove that there are ketone body present. Test plasma with keto sticks, okay, or take a fingerprint sample for beta hydroxybutyrate measurement, or you can also measure urine, okay, or you can smell the breath also. So these are the different types of ketone. Third point, confirm there is metabolic acidosis by doing ABG, okay, and ABG has got different component, you all know that, pH, okay, then PCO2, PO2, and bicarbonate. So that will clearly tell me that this is a case of metabolic acidosis. Now, what are the other investigation we like to do in case of diabetic ketoacidosis? See there? Just go through that list now. We have already done blood glucose. We have to go for urea and electrolyte just to make sure kidneys are well perfused. Full blood count is a standard part of the investigation, because intercurrent infection can precipitate a diabetic ketoacidosis state in type 1 diabetes. So we have to make sure there is no ongoing infection there. Blood gas measurement we already done. Blood and urine culture, again to diagnose is there any infection there or not. Chest x-ray, again for the diagnosis of infection. ECG, okay, ECG is important, part of our investigation. This is a case of diabetes, remember. Who knows, there may be some, coronary artery disease already. This is one explanation you can give. And another one, this may be, associated with potassium imbalance, and potassium imbalance can result in arrhythmia. Cardiac enzyme, just to rule out coronary artery disease. Now with this, let's enter into the management of diabetic ketoacidosis step by step. So the phase 1 management means patient is admitted to the ICU first. This is a serious condition. It can be managed in the ward, but ICU is of course preferred. Insulin is a very important drug in the management, because this is seen in type 1 diabetes. Then there is no insulin inside the body. So we have to give insulin from outside. That is usually soluble or regular insulin. Okay, it is given IV, 6 units per hour by infusion, or 20 units by intramuscular injection, followed by 6 units intramuscular hourly. You don't need to remember the dose, This is purely the, ICU type of care. You just know insulin is very important for the management. At the same time, fluid replacement has to be started. This patient is probably in shock or severe dehydration. We need to correct that. So 0.9% sodium chloride with 20 millimole potassium chloride is added there, and it is given to the patient. An average regime of the fluid would be 1 liter is given in 30 minutes, then 1 liter in 1 hour, then 1 liter in 2 hours, then 1 liter in 4 hours, and then 1 liter in 6 hours. Just see there how much fluid the patient needs. A lot of fluid, because this is a hypovolemic state. So don't be afraid to give fluid to the patient. Adjust potassium chloride concentration depending on results of 2-hourly blood potassium measurement. Now, potassium is excreted actively in the urine because of osmotic diuresis. So I need to give potassium here. Okay. One important point, probably you are remembering, what is the association of acidosis with potassium balance? What is the relation of acidosis and potassium? Anybody?
Sir, in acidosis, the potassium comes out into the cell leading to hyperkalemia.
Good, very good. Okay, so I just want to remind these important points here. Now, some of the students may be asking question to themselves at this stage. If potassium is coming out of the cell, which leads to hyperkalemia, then why we need to give potassium from outside? And that is a very genuine question, which should come in your mind. Remember, we still have to give potassium though that is occurring because a lot of potassium is excreted in the urine also. Okay, so we are still in the phase of potassium depletion here. So potassium is given along with the IV fluid, but make sure patient pass urine first after giving IV fluid. If patient has already developed kidney failure, means there is no urine production, I should never give potassium from outside. Okay, this is very important practical knowledge. Wait for the first urine output in this type of patient, and when you are quite happy, yes, kidneys are functioning well, add potassium on the IV fluid. If blood pressure is below 80 millimeter of mercury, give plasma expander. Plasma expander means colloid. And if pH is below 7, give 500 ml of sodium bicarbonate, okay, with potassium chloride. Repeat if necessary to bring pH up to 7. This is the management of metabolic acidosis. We are giving sodium bicarbonate also according to the situation. Let's move on. So till now, what I said, what are the three important management here? One is insulin, another is IV fluid along with potassium, and sometimes even sodium bicarbonate if necessary. Phase 2 management is started when blood glucose falls to 10 to 12 millimole per liter. See this, still in the diabetic range. More than 11.1 is still in the diabetic range, even in the postprandial. Forget about the fasting here, okay? Then we change the infusion fluid to 1 liter of 5% dextrose plus 20 millimole of potassium chloride 6 hourly. Now an important question comes here. This is a case of diabetes. Then why I am giving 5% dextrose containing fluid? Who can answer this? What is the necessity?
Sir, maybe, sir, there is to prevent the hypoglycemia, sir. That's why we are giving dextrose.
Okay, good point. Anybody else? One other student, please. Why? Why 5% dextrose? Why I have changed the IV fluid to 5% dextrose now?
Sir, because we are giving insulin and insulin will cause hypoglycemia to make sure it will not
Exactly.
occur.
Exactly. So both of the students are answering in the same way, and they are absolutely correct. Please listen here. Insulin is the drug here. Okay, and insulin has important side effect, that is hypoglycemia. So insulin will cause hypoglycemia, means it will decrease the blood sugar level, but I cannot stop insulin. Without insulin, the state of ketoacidosis is never controlled. So to counteract that effect of the insulin, I need to give 5% dextrose. Continue insulin with dose adjusted according to the hourly blood glucose test result. Okay, so according to blood sugar level, you have to adjust the insulin. Probably you need to decrease or increase according to the situation. This is phase 2 management. Phase 3 management means once the patient is stable and able to drink or eat normally, transfer the patient to 4 times daily subcutaneous insulin regime based on the previous 24-hour insulin consumption. This is a bit of practical description, but still let me elaborate on this. The patient is out of the shock. Patient is out of unconsciousness state, if there was any. Patient is stable now. Patient has started to eat and drink. So transfer this patient to the ward. You don't need to admit this patient in the ICU anymore with 4 times daily subcutaneous insulin regime. Now, how I know what is the required dose? This is provided by the previous 24-hour insulin necessity. How much regular insulin you are giving? Accordingly, you convert that insulin in the subcutaneous form. Now, some of the special measures, okay, when we manage this diabetic ketoacidosis are start broad spectrum antibiotic if infections are likely. don't hesitate to use this antibiotic because infection may be a precipitating factor for diabetic ketoacidosis. Bladder catheter if no urine is passed in 2 hours. Urinary output monitoring is very important step in the management. Nasogastric tube is placed if patient is drowsy. Consider CBP pressure monitoring. This is central venous pressure. If patient is in shock or if previous cardiac or renal impairment are there, CBP pressure monitoring has to be done. Who knows, by giving a lot of fluid, patient may develop heart failure or patient may develop renal failure already. So CBP measurement has to be done. And give subcutaneous prophylactic low molecular weight heparin because this is a thrombotic state. So low molecular weight heparin has to be given. Thrombotic state is caused by dehydration as well as hyperglycemia. So we need to think like that as well. Let's move on. Now, what are the subsequent management now? What we need to do? Monitor glucose hourly for 8 hours and make sure it is normal. Monitor electrolyte 2 hourly for 8 hours and adjust potassium replacement according to the result. And everything is fine or satisfactory, then you can discharge the patient. So this is about the management of diabetic ketoacidosis. Now let's move on to the second, metabolic complication or acute complication of diabetes, that is hyperosmolar hyperglycemic state. This is an important acute complication of type 2 diabetes now. Type 2 diabetes. Now see there, severe hyperglycemia develops without ketosis in this condition, and this is usually occur in type 2 diabetes. Patients present in middle or later life, often with previously undiagnosed diabetes. Sometimes they may present for the first time in this state, hyperosmolar hyperglycemic condition. Similar to the diabetic ketoacidosis, there are certain common precipitating factors, and they include consumption of glucose-rich fluid. Now, this patient is very ignorant to the diet advice, or the patient may not know that he is already a diabetic patient, So if they drink some juice, which has high amount of sugar, they simply present with this state. Concurrent medication like thiazide diuretics or corticosteroid, these are hyperglycemic drug. You already studied them in pharmacology. One of the side effects of them is hyperglycemia and intercurrent illness. This is a stressful situation. Counter-regulatory hormones are secreted and they can again lead to hyperglycemia. So they can simply act as a precipitating factor. So good history has to be taken. Now, all of you, please focus here. These are the electrolyte changes in DKA and hyperosmolar hyperglycemic state. And this slide is just comparing, okay, the difference in electrolyte changes between these two conditions. So here is sodium, potassium, chloride, bicarbonate, urea, glucose, and pH. This is a severe diabetic ketoacidosis, and this is hyperosmolar hyperglycemic stator condition. Look at the level of sodium here. It is 140. This is just one example, Patient may not follow this, but this will provide us the concept. Here, 155. Potassium is 5 here. It is also 5. Chloride, 100. It may be 110 here because of the dehydration, Severe dehydration. Fluid is lost more than the electrolyte in this situation. Bicarbonate, 5. Here is 25. Now, can you tell me why bicarbonate is 5 in a ketoacidosis but 25 in the hyperosmolar state? Why? Why is this? Anyone? Because this is a situation of metabolic acidosis. Metabolic acidosis is all about decrease in bicarbonate level. It doesn't cause any metabolic acidosis, so bicarbonate value is normal. Urea is 8, it is 15, okay. Glucose is 30 and it is 50. See here, look at the difference in the blood sugar level. This is massively high, 50 millimole. 50 millimole, if I multiply this by 18, it will be 900 milligram per deciliter of blood glucose. And here it is 540. Just one example again, it may differ, it may not follow exactly that. Sometimes it may be 250 or 300 and it may be 600 or 700 like that. Arterial pH 7 and 7.35. It is very low, it is almost normal. Now, another important concept here is we have to measure the osmolality. Now, if we measure the osmolality, what is the normal range? The normal range of osmolality is 285 to 300 milliosmol per kg in a normal people. And it can be measured directly or can be calculated approximately from this formula. Now, please pay attention. The formula is about, okay, we add sodium and potassium together and we multiply by that 2, and on that we add glucose and urea. So for instance, in the example of severe ketoacidosis which was given above, the osmolality which we have calculated is, see this, 140 was the sodium there and 5 was the potassium. So you add this together, so it will be 145 multiplied by 2. Okay, then you add 30, that is a sugar, and urea was 8. So it will become 328 milliosmol per kg. Whereas in the example of hyperosmolar hyperglycemic state, see there, the sodium was 155 in that case. Okay, the glucose was 50 and urea 15. So if we calculate, it will be 385 milliosmol per kg. And what is the normal range of osmolality? It is between 285 to 300. So the take-home message here is serum osmolality in case of hyperosmolar hyperglycemic state is very high. Means the blood, okay, is very thick here. Okay, very thick, hyperosmolar. Let's move on. This is an important question which may be asked in your clinical problem solving questions. Okay, so you need to calculate. We'll give you one clinical scenario like this and ask you to calculate what is the osmolality here. Now, after doing that important exercise, let's talk about the clinical features of hyperglycemic hyperosmolar state. This is a feature of type 2 diabetes. The characteristic clinical feature are dehydration and stupor or coma. Stupor is our stage just before the unconsciousness level. Impairment of consciousness is directly related to the degree of hyperosmolality. Now, there are 2 causes of stupor or coma here. One is dehydration, severe dehydration. Another is hyperviscosity of the blood. When the blood is very thick, it cannot flow properly in those small capillary, remember? So that may simply add on the process of unconsciousness. We need to find out, is there any underlying illness in the patient or not, like pneumonia, pyelonephritis, skin abscess, anything like that. Any evidence of infection is there in the body or not. Another point, hyperosmolar state may predispose to stroke, myocardial infarction, or arterial insufficiency in the lower limbs. Again, because of ischemia, because of too thick blood, it cannot flow properly in those areas. And second, has to be contributed by hypovolemia or the shock state. These are the investigation. They are the same, just like diabetic ketoacidosis investigation, same one. But there is one small, difference, that is the plasma osmolality. If we calculate it, it will be extremely high. others are the same. And regarding the treatment, many patients are extremely sensitive to insulin. Now, one question, why we should give insulin here? Why? Anyone? Why insulin is given here? Because in this situation, okay, the oral hypoglycemic agent may not work, or they, even if they work, they take a lot of time to decrease the sugar level. Blood sugar level is so high, okay, so directly insulin is given, that is regular insulin. The resultant change in osmolality may cause cerebral damage, so do not drop the level of glucose dramatically. You have studied this concept already. There should not be any undue change in the osmolality between extracellular compartment and intracellular compartment. We should give time for that to adjust. Okay, if the intracerebral environment, that means I'm talking about the osmolality now, is decreased suddenly, fluid may enter there. So all these things can happen. The standard fluid for replacement is 0.9% physiological saline or normal saline. So this is how the hyperosmolar hyperglycemic state is treated.